you, Linda, and welcome everyone. I see many names that I know, and especially a lot of my students. So thank you, especially to you for coming. I really appreciate it, and I was really looking forward to doing this seminar today about the bridge building project. And I was excited to see so many students here because, as many of my students in the room know, I'm teaching on the public health module in level 5 of the health and social care degree. And this is hopefully an example where we can put some of the knowledge about health promotion and public health theory into practice. So I'm going to talk about this project that was kind of done as a part of the COVID-19 response in the local area of Norway. That happens to be my home county, my hometown, as I spent a great deal of the pandemic in that town. So I'm going to keep my camera on because then I can gesticulate and communicate better. But if I'm lagging, I shouldn't be because I'm on the edu roam. So do let me know in the chat or give me a wink. So before I start, I'm a senior lecturer in health and social care, and I'm also a PhD student in the School of Social Sciences and Professions. And my research focus in my doctoral degree is a little bit different than this, but it also kind of links together quite nicely. So I'll explain a little bit more about that. Today, I just thought I could go through the project, as it were, delivered in Norway, the context of and the background of the project, the theoretical framework that kind of guided the project, and explaining the strategy and some of the kind of early impacts that we saw from this project. So the project aim was to address inequalities between majority and minority populations in uptake of testing, vaccines, adherence to social distancing and isolation measures, and as well as success rate of contact tracing. So some of the key stakeholders involved in this is obviously the ethnic minority population in the Sandefjord area of Norway, the local authority, the healthcare professionals within the COVID-19 local response team, as well as the wider healthcare sector. The strategy was using best practice from Oslo, which is the capital of Norway, which has a much more experience of working with ethnic minority populations. And using key resource persons from ethnic minority backgrounds to support and promote health within target populations. Now, this project started quite late during the pandemic in February and only ran until September 2021, when the Norwegian Public Health Services kind of declared the end of the pandemic in Norway. Importantly, the indicator was that in Norway, the COVID-19 infection has proven now to be less deadly and less causing severe morbidity than the normal influenza. So that was a big event that happened in the end of last month. And it speaks a little bit to the successful handling of the COVID pandemic in Norway, but also I think it speaks to the level of health that's already in that population. So there's a lot of factors kind of impacting on the successfulness of how Norway handled the pandemic. So I just wanted to bring some key facts about Norway, because I know I always talk about Norway to my students and probably to most of you who I know in this room, but it's a small country of the total population approximately 5.4 million people. Within that, just under 1 million non-Norwegian born citizens and asylum seekers. Main countries of origins for non-Norwegian born citizens are Poland, Lithuania, Somalia, Pakistan, and Sweden. The population density is quite low, and there's only 38 people per square mile versus 700 people per square mile in England. And much of the settlement in Norway is quite rural. The general health of the country is considered quite good, and again, this has an impact on how well Norway was able to handle the pandemic. The life expectancy at birth is the 17th highest in the world, with the average life expectancy between genders at 82.94 years. The Gini coefficient, which is the indicator of equality in the country, is at 0.26 or 26, and that's 6 globally for most equal countries in the world. There are still social inequalities in health, in particular in terms of life expectancy, where people from lower socioeconomic backgrounds on average live about 5 or 6 years shorter than their wealthier counterparts. The life satisfaction rate is very high. According to the OECD survey of the 40 OECD countries, Norway ranks second. So it's a safe country to live and grow up in, and also a country that has a high level of health overall in the population. So a few key statistics on the COVID-19 pandemic in Norway as it stands today, or yesterday, 19th of October. So the total cases is just under 200,000, which isn't particularly high. Total hospitalizations is also a quite low number at just over 5,000. And the total intensive care hospitalizations are also quite low at 1,000, just over 1,000 emergency or total intensive care hospitalizations. Total deaths is also quite low. 884 deaths in total since the start of the pandemic. We have quite a successful and efficient testing strategy in Norway, and have been able, with only the small population of 5.4 million, to administer over 8 million PCR tests. This is only the PCR test and not these home tests. So I thought that was quite a handsome number of tests on such a small population. So I just wanted to do some comparisons on the kind of the cases. This is per 100,000 population. So of course the UK is a much bigger country, so we can't really compare directly. New confirmed cases of COVID-19 in Norway is the blue line, and the UK is the red line. Between March, 1st of March 2020 and just the end of September. So you see the rates have kept quite low, with kind of a top as in the end of August, where a lot of the restrictions ended in Norway, and also travel seemed to perk up at that time. I wanted to compare to Sweden. So if you've been following in the media, you know that Sweden had a quite distinct COVID-19 strategy compared to Norway and compared to most other countries, and have seen a much higher number of deaths to COVID-19 than Norway, particularly in the early stages of the pandemic. But have seemed to settle at quite a low level, similarly to Norway recently. So just wanted to show the scenic picture of Sandefjord, where I'm from. I'm from the very top end, just under the word "and." I think just about there I was born. So Sandefjord municipality is a city for us in Norway, a big city of over 40,000 people. For most people here in the room, probably a very small city. So it's relatively non-diverse compared to other contexts and countries. City has some affluent history, Sandefjord is part of a county which has traditionally some of the highest rates of social inequality in the country. Some of the heritage of the city include shipbuilding and whaling, which could have an effect on the level of inequality seen in this area. So the population is approximately 45,000 people spread across these urban and more non-urban areas. There's virtual non-representation of ethnic minorities in the local council or in the local COVID-19 response team. So for not of lack of ethnic minority populations in the area, the kind of infrastructure for diversity is not very well developed in this area. So thinking about tackling the COVID-19 pandemic, in general, in Norway, the COVID-19 response teams are locally run with guidance and support from the Norwegian Institute of Public Health, FHI. So generally, the efforts to tackle the virus has been found quite effective and efficient with a very high level of adherence to measures. Local authorities set their own strategies in testing, tracing, quarantining and isolation with guidance from the Norwegian Institute of Public Health. And local authorities employed students, former healthcare professionals at pension age, and newly trained staff so as to not burden the assisting workforce in health. So compared to the strategy in the UK, it is much more local based, and perhaps we see some of the successes from the response to COVID in their very local strategy. So looking a little bit around the problem that we faced in Sandefjord when I kind of came onto the scene in the COVID pandemic, and starting out just on the side contact tracing for the local authority, and becoming aware of some problems facing the area, but also facing the nation as a whole. So persons with migrant background have high risk of COVID-19 infection, serious illness and death. And this is something, of course, that's mirrored through various countries, populations across the world, and also in this country. So we have some research from the Norwegian context supporting this. There was a low uptake of testing among ethnic minority populations throughout Norway as a whole, as well as a high test positivity rate, meaning that when the tests were taken, you were more likely to test positive. If you were, for example, Norwegian-born parents, than if you were Norwegian-born with Norwegian-born parents. And that indicates that there's less testing going on among that population. So it's a good way of measuring kind of the testing. So there was no targeted effort towards ethnic minority populations in Sandefjord until spiking infection amongst ethnic minority populations in the early kind of 2001. So Digby says the causal factors seem similar to the UK. Absolutely. I think many of these things are very, very similar. And I guess some of the mitigating factors or the protecting factors, I think that's where we probably differ. So there was targeted efforts recommended by the Norwegian Institute of Public Health, and in this publication for Brødberg and Himmels, and our intervention was also published in their review of Norwegian targeted efforts towards the ethnic minority population, that I think is published very recently. So what I noticed coming into the contact tracing team as a nurse was that there were frequent breakdowns of communication between the contact tracing team in the local authority and new COVID positive people. And especially this would regard people from ethnic minority backgrounds. So what was the kind of anecdotal evidence was that there was lack of adherence to self-isolation and quarantine measures. There was a lot of frustration among the contact tracing team, and there was growing evidence of vaccine hesitancy and low local uptake amongst ethnic minority populations. So this was something that was quite frustrating for the local contact tracing team. And also something that we didn't know much about because there was no directed kind of data collection or anything systematic going on to try to capture the problem. So coming into this problem, it was quite a challenge to wrap my mind around what was going on, because so much of these problems were so practice-based, so based on kind of the individual experience. And this was a team of I think about 7 nurses working with this in this local area. So it's quite small, quite limited. So after doing some research on the issue widely, nationally, and especially in Oslo, where they have more experience working with and for the ethnic minority populations, our aim was to address inequalities between majority and minority populations in the issues that I already mentioned: uptake of testing, vaccines, adherence to social distancing and isolation measures, and success rate of contact tracing. So some objectives were to utilize local resource persons with relevant ethnic minority backgrounds to run the project. So we wanted to make it so that this was a project run from the bottom up kind of approach rather than the top down approach. And I know we spoke about this in our public health class for the students that are here. To try to see if we could gain some more insight into the actual barriers and challenges facing the ethnic minority populations with regards to COVID-19. We were also very cognizant that when there is a small area, a small local area, and when people hear that members of certain ethnic groups, for example, are not compliant with rules, it tends to feed into a kind of a negative opinion, and racism and discrimination can follow very closely with that. So we were very cognizant of this, and this was part of why we felt it was important to tackle this very urgently. We also wanted to develop some health promotion materials through participation and co-production with the local resource persons that we wanted to utilize in this project. So some of the theoretical framework that we tried to build this project around. I've spoken to about this with my class, and I think many of you are probably familiar with the kind of various approaches to behavior change and to health promotion. So looking at the health belief model, it's kind of a useful framework, albeit quite mature in understanding people's health behaviors as a result of their beliefs regarding the health issue. So if people think that they are in threat of COVID-19 infection, if they're susceptible to severe illness or hospitalization or even death, or if they believe in the effectiveness of the measures that is being proposed to them, for example, lockdowns or quarantining or self-isolation, or even medical interventions such as vaccines. So this is kind of to predict the likelihood that the person will adopt the behavior. So I think this kind of conforms some of the understanding of how we kind of designed our interventions. So we used some kind of principles from social marketing theory, of course, when we designed our health promotion material. So understanding audience segmentation and targeting, understanding what kind of language to use and who to speak to about what. And we were quite specific in our development of health promotion materials to ensure that we were kind of targeting the specific message that was needed. And that information we got from people working with us directly. Another example of kind of a bottom-up approach. So competing for attention in the crowded market. The crowded market wasn't that crowded because it turns out that information in the Tigrinya or in Polish or Lithuanian isn't that common in a small town like Sandefjord. So once we produced that kind of material, it was quite easy to get attention. Branding, ensuring that we kind of kept a certain standard of our brand and for recognition across different platforms. So we worked a lot with trying to empower people in their health, and understanding health is something that kind of is based around your own personal qualities and capabilities, as well as being kind of sourced from the wider socio-contextual environment. So the support that we receive from social networks and wider society. And of course, we're working with populations that have a varying degree of trust with the health authorities. What we found is that many have a great level of distrust towards health authorities as part of the reason why they wouldn't engage with isolation measures, for example. So we're focusing this project on the actual COVID-19 pandemic, but also in a way, and I'll talk more about that in the end, also a way to kind of empower the people working with us to become aware of their own power over their health, and also to apply that for future context, which they have, and I'll talk more about that later. So this is kind of the strategy that we kind of applied for this project. So on one side, we have the local resource persons, or what we call bridge builders, in contact tracing, working directly with them. And then we have the development of health promotion material. So we recruited 6 people with ethnic minority backgrounds from Eritrea, Somalia, Syria with Kurdish and Arabic background, Poland and Lithuania. These countries were chosen because of their presence in the local community, but also on the basis of the increasing cases, especially within these populations. So the people that we recruited have backgrounds in teaching, health, even hospitality. And for some of the bridge builders, this was the first formal employment they've held in Norway. And for many of them, it was a pathway into more secure and long-term employment. So the bridge builders, they were trained in basic contact tracing. They also managed their own individual cases of supporting COVID positive persons in isolation or surrounding those in quarantine. They disseminated information to travelers in our local airport, which is quite a large airport that usually has a lot of traffic from Eastern European countries, and also in the local quarantine hotels. I didn't get that in my slides, but we had very large quarantine hotels in the area taking thousands of people every week. So the bridge builders kind of were employed to be building bridges and disseminating information from the health authorities and through the patients and the people in the airports and in the quarantine hotels as well. So the health promotion material that we developed, we did through active participation, co-production with the people working for us, the bridge builders. So they were designed, the leaflets and the video that I'll show you in a second, were designed to focus on the particular needs of the specific population at hand. So we had different kinds of information for the people from, for example, the Eastern European countries, where most of our challenges were with travel and issues around quarantining and testing, whereas some of our other the countries that were represented were more concerned with the kind of the home environment, having guests or company, celebration of religious feasts and celebrations, etc. So these materials were all delivered through a series of workshops that we had together, which was a long and kind of painstaking process. And co-production and participation and empowerment, it takes time. And it's sometimes probably easier to just get on with it yourself. But I think there's a lot lost in terms of potential there. So those kinds of processes take a lot of time, and there was perhaps not a lot of understanding of that within the kind of the higher ups in the local authority. But we've powered through, and we developed some really good material in Norwegian, and we translated them, and the bridge builders translated themselves. But we also certified our translation and quality control them through certified translators as well. So we disseminated our campaign through various channels, both on and offline. So importantly, we worked with a local charity that provides work opportunities for local ethnic minority women. And they did a big postal campaign for us where they went out on their bicycles and they posted letters in the corresponding networks that they had in the ethnic minority population. We targeted and disseminated information online through networks such as WhatsApp, Facebook. Anyone who's a migrant will know that you usually connect with other migrants. So because I'm a migrant to the UK, there's a Norwegians in London Facebook group, and you always ask each other advice. So that's probably true for many, many different nationalities. So there was a lot of those informal online networks that we used really consciously. We also use the bridge builders networks in schools or colleges. Many of them were still in language classes. We also used places of worship as a way to connect with people and let them know about our health promotion campaign. We also partnered with a communications bureau to target online advertisements to the specific populations that we were looking at. And we could do that in all of these languages apart from Tigrinya, which is the language of Eritrea. So that was quite successful as well. So this is an example of the kind of the brochures that we made in different languages. The Polish flag isn't correct. This is just my my formatting of my slide that makes it a kind of a purple little thing there, burgundy. So these were made, and they have a corresponding QR code, and that QR code leads to a online area where you can, at the risk of this information not being updated, because of course you print one thing about the pandemic and then the next day the government changes something. So we needed to have an online presence, and that was communicated through this QR code. I'll show you this little video that's called "We're Saying Yes to the Vaccine." There are many different languages in this video. You might recognize some of it. I'll try to share it with you. I'll send it in the chat. It's very short. I'll send it in the chat, and I'll also try to share it with you in my on my screen in a second.
Jeg sier ja til vaksine, slik at vi kan stoppe viruset og skape flokkimmunitet.
Jeg sier ja til vaksine, slik at jeg og min kjæreste kan reise.
قول نعم لأخذ لقاح ضد كورونا لأنه فينا نسافر لأقاربنا بكل بلدان العالم بدون قيود أو حدود.
Jeg sier ja til vaksine, så barn og ungdom kan få den friheten de trenger og fortjener.
Jeg sier ja til vaksinen, slik at vi igjen kan reise på fotballkamper og konserter sammen. Aš sakau vakcinai taip dėl to, kad galėsiu keliauti ir susitikti su savo tėvais.
Mówię tak dla szczepionek. Nie muszę się już martwić i mogę żyć normalnie.
All right, that was that tiny little video, and we were quite proud of that because we made that very collaboratively in the team. And for those of you who know me, I'm not great at anything to do with IT, so we utilized all of our strengths in our 7-person team to recruit for that video and to make it. And even though it's only a few seconds long, it takes a while to make that. So those are the materials that we made in our health promotion campaign, and I wanted to just share some of the kind of the impacts that we had through our campaign, even though the impacts perhaps can't be seen fully yet. So after the initiation of the project in February 2021, something really important that we saw was that there was increased contact between contact tracers and COVID positive persons. This was not only for the contact tracers who was a part of the bridge building project, but is also for contact tracers in general. So when there is increased contact between contact tracers and COVID positive persons, you're more likely to be successful. And we did see an increased amount of contacts traced, meaning that connected to each COVID positive person, we were able to identify, particularly among the ethnic minority population, we're able to identify more connected cases. So we had less unknown pathways of contagion, which was something that we were very proud of in the local authority. We had almost no unknown pathways of contagion in our local area. So we always knew where the contagion had come from, and to be able to do that and to be able to trace so successfully, you have to have a lot of support from the actual population and a lot of trust between the population and the health service and the contact tracers themselves. And I think that was a key success of the project, and something that we would measure every week, and something that really grew in this project. Something that was really palpable was also the lack or less frustration among the regular contact tracing team, especially toward the issues surrounding the ethnic minority population. There was obviously a reduction of COVID-19 cases, but we have to kind of see that in connection with the general decline of cases nationally as we moved on to the spring and the summer. And none yet observable changes in the vaccine uptake, and this data is kind of pending from the local authority. So to kind of sum up and some kind of reflecting on this project. Now, when I say we, I mean me, because this project was a kind of from the beginning a solo effort, and where I was able to recruit several people working with me throughout the project. But I really quickly understood that using collaborative and participatory approaches to health in Norway is still quite novel. And I can't speak for the whole of Norway because it's a big country in size at least, but at least in the local area where I'm from, this is still quite novel. So there were some barriers to doing this successfully, which included lack of representation of ethnic minorities, as well as lacking an infrastructure for diversity and for inclusion. So working a little bit against the grain there, and trying to make the best of what we had in our local authority. And what I think is really important, unrelated to COVID perhaps, but important in a kind of a health empowerment perspective nonetheless, was that the bridge builders are taking on other and really important roles in health, in building bridges in the local community through different kind of health-related projects in the Office for Public Health in the local authority, and also being utilised for data collection in the upcoming local residents' health and well-being survey. So that's also a very tangible kind of important impact non-COVID related, however. So that's a little bit about this project. I was quite efficient in my use of time, so I'm happy to take any questions or comments from the people in the room, and thank you for listening.
Okay, thank you, Maja. Thanks very much for your presentation. I think, yes, questions are open to the floor. I think we have, I'm checking on the chat box. I wondered if you would like to take some of these already being raised. For example, Digby Warren says the causal factors seem similar to the UK. I'm not sure if you would like to comment on that.
Yes, I quickly commented on it, but yes, you're right, Digby, that the kind of causal factors for the disproportionate impact of many health issues are very similar in any kind of Western, I guess, context. And I think what probably protects a lot of ethnic minority populations in Norway is the general higher kind of standard of living, quality of life. And I do think that probably was a kind of a mitigator for the impact. And as we saw in the beginning, the actual deaths and serious cases of COVID stayed very low, even comparatively to the population in Norway. So I think all in all, it's been a very successful effort. And I saw Olive had a question as well. She said, yes. I'm wondering how language differences and barriers were managed within the project team. Yes, so the project team was very small because it was only me and 6 other people. But I will say, perhaps the other Norwegians in the room, I thought I saw one, that dealing with minorities in a setting, a team where minorities are usually not present, you're confronted with many issues of stereotyping and the prejudice. And this was definitely something that I saw very clearly on this team. There's a generational issue there as well, but I think it could be the start of something more inclusive and diverse in the local area. And kind of I believe that the benefits really outweighed the challenges that we had in working with each other. So should I answer the other question, Yolanda?
Yes, I'm moving through the, so lots of congratulations on your talk as I go along. It was amazing indeed. And you can, Diane Smith, she's asking, are you considering continuing to track the impact of the project?
Yes, so I think I really want to write this up and try to publish it, which should always be a goal of any academic, and then trying to do that, and then also tracking the kind of collecting a little bit more detailed data on the actual impact that we had short term, and also that maybe something more on the long-term impacts and what can be done in the infrastructure of the local authority to keep this kind of idea going and this kind of project going for other health issues. So yes, that's definitely something that I should be getting on with. Thank you, Diane.
People can also use the mic. I don't think I mentioned that already. So you can pop your hands up.
Yes, Telly has his hand up.
Telly, would you like to ask a question?
Yes, so very good, well done, Maja. I just wonder, there's just a couple of things. There's your theoretical framework, the empowerment, empower communities, and the use of bridge building. 2 points. This key theoretical area you might want to consider the social capital theory to help you develop some of the concept on bonding, bridging, collaboration, and participatory work and trust. I suppose the key question I want to ask in trying to identify people from the minoritized communities, did you find that there were untapped resources in terms of their experience, qualifications prior to arriving at in Norway, that there were really quite a lot of resources within the community that were not used or underutilized?
Yes, thank you, Telly, and thank you for that on social capital. And I'm in my my doctoral studies, I've been working a little bit around theories of citizenship as well, which is similar. So I agree with that, and that's probably a very good kind of theoretical kind of angle as well. Yes, I think there was so many untapped resources, and it's typical probably of the migrant population that there is, and I think there was other projects that have been tried and tested before in other contexts in Norway, where there was more of that top-down approach, where kind of the interventions weren't tailored to the specific populations, and something that could really kind of further kind of divide the population. So absolutely, I think there's a lot of untapped energy and knowledge there that was utilized, and I think to some people's surprise in that local area as well. All right, I'll just see if there's another question. I don't know if Yolanda's here or if Kath has a question. Go ahead, Kath.
Hi, Maja. Thank you very much for an interesting presentation. I spent quite a bit of time in Sweden when COVID was particularly unraveling, and all the Nordic countries, including Norway, were having lockdowns, and Sweden was having a very different approach. And what was fascinating about your presentation is how ethnic minorities were responding in Norway, because in Sweden, it felt like the opposite, because minority groups were kind of like exposed to international news, whereas Swedish people tend to be very inward looking. So if I went, for example, to the supermarket wearing a mask during that time, hello, can you hear me?
Yes, we can hear you, Kath.
Oh, okay, sorry, my laptop just played up a little bit. I thought I disappeared. So if I went to the supermarket, for example, wearing a mask, and then everybody will be looking at me in a very, very strange way. And there were like incidents that were being reported in the expert newspaper where ethnic minorities were being much more cautious. And when they were, local residents looked at them as if they were completely out of it. And so the whole thing to do with mask wearing, and also being forthcoming in terms of going for COVID testing, and I kind of like wondered in terms of the minority groups in Norway, I wonder whether there's a difference in the profile, or because in Sweden it was quite the opposite, where you have a government that is being very different with its approach, and then you've got these ethnic groups who are so weary of COVID because they are listening to international news and they can see what's happening elsewhere.
Yes, I think there's definitely the biggest difference, is, I'm sure, is how the pandemic was handled, and perhaps some of the ethnic minorities in Sweden felt that they were treated as kind of collateral damage, as I know was kind of the issue with older people, and there was a very kind of a clear strategy of herd immunity that would obviously negatively impact the vulnerable population. But I also think that there's a greater deal of kind of issues surrounding migration in Sweden than in Norway, and perhaps a little bit more volatile. That in the baseline, and that kind of environment is a little bit more hostile at times, which I think could have an impact.
Okay. That's interesting. And I think the other thing I wanted to ask was about the issue of non-compliance, and what you thought were the reasons behind that. Because I did a research project over summer, and I was basically interviewing women over the phone because obviously there was lockdown and I couldn't do face-to-face interviews. And one of the key issues that came up unexpectedly was that you had, it was with migrant women, Black African women, was the challenge that they, obviously if someone tested positive for COVID, they couldn't go to work. But at the same time, some of them were not, they didn't have access to public funds. You know, there were no recourse to public funds, people basically. So in terms of hesitancy to get tested and non-compliance, I wondered whether the economic factors played a key part in terms of the migrants in Norway, because in terms of the research I was doing here, I could see how not having access to resources was having dire consequences for people who had to isolate. Maybe someone, not even them, probably someone else had tested positive, but they were still going out to work underground because they had to.
Yes, absolutely. And when we kind of did our workshop and our focus groups with our very limited number of bridge builders, we did see that many of the kind of barriers to testing and, you know, adhering to social isolation measures in general, of course, when you were positive, as well as contact, was surrounding work. And even though there is much protection, and that's definitely one of the mitigators when it comes to the successfulness, you know, or the lack of kind of big scandals when it comes to the COVID-19 pandemic in Norway. But I think that kind of the policies to protect people in very precarious work, and of course those who fall into precarious work are often disproportionately belonging in the ethnic minority populations. So absolutely. So it wasn't all kind of the beliefs around the health issues, and it was probably more of a kind of an ecological kind of issue surrounding more structural things like work and access to funds or access to sick pay, etc.
That's interesting. Thank you.
Thank you, Claire. So I'll just read the question. So Henry Kidunsi, thank you for your question. How the study or project results been used to inform health policies in Norway? Well, they haven't yet, which I think they were doing some pilot projects of similar things, and this project was kind of conceived from a pilot project that was done in a specific area in Oslo, which is an area of Oslo where there's a high kind of density of people, and also a high density of people from ethnic minorities. So I believe it's been kind of tried, it has been tried in other areas of Norway. And I mentioned the Norwegian Institute for Public Health report. So we were included in a kind of a write-up of different initiatives going on around COVID and ethnic minorities that I believe I can circulate because I believe at least an English abstract of that. So where they kind of try to collect best practices from across Norway on this matter. So we hope that that could help inform health policies in more generally in terms of health and how we work with health with ethnic minority populations.
Maja, I have a question. Can you hear me?
Yes, Yolanda.
Yes. I think it's something that is at least very important here in the UK, is the issue of trust in public health, in particular because it has been pretty much undermined, I mean, in terms of public health and government initiatives to control the pandemic. But the question, you mentioned it as these minoritized populations being lacking as well, that trust in terms of measures. I wondered if you did you approach this co-production design knowing beforehand that that was already an issue within Norway, or was something that somehow, let's say, intuitively you develop for your case?
I think it was part of the kind of the preparation for the project, and the research that I did to prepare for the project was quite clear from the literature and the data that there is issues of trust among the migrant population. However, many of those studies refer to people that are either undocumented or asylum seekers. So many of the COVID positive people that we worked with in our project were people that had been in Norway for many, many years, perhaps even second or third generation migrant with a migrant background kind of in their heritage. So it was interesting to see that kind of reproduce and to try to understand why that is. It's very complex, I think. And of course,
yeah. Yeah, sorry. Carry on, sorry.
Yeah, sorry. And of course, it's different kind of barriers to participation, access to healthcare, and I think representation is generally a big issue in Norway, where there is quite a non-diverse population anywhere but the very large cities. For example, in Oslo. So when ethnic minority populations tend to concentrate as they do, in London versus the rest of the country, I think in general there, in most areas of Norway, there's a lack of representation. And I think some of the bridge builders I worked with, they were quite surprised to be included in such kind of high levels of decision making. And that kind of talking to Digby's question as well, the changing attitudes and perceptions that people had of each other, I think was really important, and something that probably I didn't measure fully, but I'm interested to go back in and try to measure, at least qualitatively, yes. That change.
I was about to say that, because I think, and this is linked also to what Diane asked you before, which is, I think it will be great to measure some of the changes of engagement through this intervention. And one of the way, at least you have, will come back to do some interviews or absolutely. Questionnaires, and both ideas. I mean, could be a way of gathering some data. Yes, because I think it's very important then to take things forward. I mean, you mentioned that changes attitude of people coming to participate. I don't know how sustainable then it is for other initiatives broadly, isn't it, for healthcare?
Right,
I mean,
exactly.
This is something that the NHS itself is interested in, although this is a very different context in the way that the pandemic has been managed, which was centralized. Local authority have practically not much saying directly in how to tackle, I mean, all the type of initiatives you are mentioning. It's not that there were not ideas, but it was just how it was very top-down manage, and therefore if you take trace and trace, for example, out of the hands of local authorities, it's very difficult then subsequently to engage in initiatives, isn't it? So
Yeah.
but I think it will be great to move forward with some data now, which is very recent, isn't it?
Absolutely.
To illuminate other initiatives moving forward of public health to rebuild that trust, which is something
Yes.
so difficult and challenging to sustain in minority groups, particularly.
Absolutely. Yeah.
I'm not sure if I'm looking at the chat back now. I think Henry is asking, how have the study or project results been used to inform health policies in Norway?
I did address that question, but maybe you were maybe you were dropping out at that point.
Perhaps.
Yeah.
Yes, apologize. And I see the last one is Digby. I don't know if it says how did the project change perceptions. I think that you addressed that too, and attitudes towards prioritized groups among healthcare workers, service, and different groups themselves. I think also you tackled that, addressed that question already. Okay. So if there is any other question, I repeat again, you can raise your hands and use the mic if that's okay with you.
Thank you for all the questions. Telly, you raised your hand.
Yes, it just occurred to me when we're talking about issues of trust and the top-down approach. If you to consider Norway in terms of the central government and local governments, there's more trust possibly between the central and local, and compared to here in England, in terms, if you look at the political context here, that over the years, the Tories have consistently tried to undermine local authorities, and there's been, over 50% cut in local government resources over the years, and it's also the fact of is this kind of a laissez-faire capitalism, which is been much more about contract. The government, the client, as well, the concept is being used is the client government, in which everything is been outsourced to private sectors, which has, in my view, totally undermined the effectiveness of addressing the pandemic here in England.
Yes, absolutely, and I think there's the less of that kind of selling out of local authorities and the running of health and social care services in local authorities, which I think is very healthy. So I think the kind of commodification of health in the local authorities could be very damaging. So the and the more kind of universal and affordable and accessible the health services are, of course, the more people will engage with them, and organizing that through local authorities, of course. There was something that we also found, what you say about central versus local government, that many of the workshops, and we worked, we found that a lot of the bridge builders said, we need to push the local authority logo. We don't need to push anything kind of central government. So there's a higher level of trust in the local government than in the central, even though the national government in Norway now is kind of on the left side of the spectrum, whereas in this local area that we have a very right-wing kind of governance. So, but I guess it's kind of the role of the central government is linked to other more contentious issues, such as migration and all of the issues surrounding that, whereas the local authority usually have a more supportive role. In terms of housing and kind of settling in their local area, and less of that kind of role of the sanctionist. So I think that's part of it as well.
Okay. Any further questions or comments? Just a brief one from me, Maja, before you go. It's about vaccine hesitancy. I mean, if you want to say something about it. I mean, I know that you say that was obviously in time. I mean, it might have come across as a topic at some point, isn't it? So if you have any data, any results, or anything that you want to share on that.
Yes, we don't have any results on the kind of the impacts of our materials on vaccine uptake, but we know that vaccine hesitancy was quite strong among especially the younger sections of the ethnic minority populations. So that was a kind of significant thing that was also mirrored nationally, and I think in many other nations it was mirrored. So we try to target particularly young people and also people working in the health services. So obviously in Norway they introduced the exemption from quarantining quite early on if you were vaccinated, which had a good impact on the runnings of the health and social care services in the local authority. But because of many of health and social care workers are from ethnic minority backgrounds, when they weren't vaccinated, it had a huge toll on the runnings of the health and social care services. So there's something that was really impactful and that we really kind of tried to address. We don't have. I'm still waiting for the kind of the data to hear whether we had any impact, and we had other kind of things happening alongside with our project to increase vaccine uptake. But generally, the vaccine uptake in Norway has been quite high, quite successful, although the rollout has been quite slow compared to the UK.
Okay, thank you. There's a question from Olive. She says, yes. How did you secure funding for the project, and did you have to gain ethical approval?
I didn't have to get ethical approval, so it was kind of part of the COVID-19 response team as a kind of an employed position, and obviously the people, the bridge builders were paid. So it was a kind of a part of a research project as it were. The funding was through the local authority, and the funding was quite handsome in terms of the pockets were quite wide and open for any projects surrounding ethnic minority health, and we also secured funds from the Norwegian Public Health Institute after we delivered our project as a part of kind of the national effort to decrease health inequalities in COVID-19.
Okay. Well, just checking any other questions. Okay. So thank you, Olive. Perhaps we can draw a session to a close then. The recording, yes, the recording will be available. We have a Facebook page within the center, and my colleagues know about it, but perhaps I will give the link, or pass on the link to Maja to circulate. It's also alongside another link also from YouTube and the research webpage from the university. So we will upload the recording there. I think this is a fascinating initiative, an excellent example to share with students as well on how all these work in real life. I think it's a great seminar in that respect, and we look forward to your results and the publications and the
Thank you,
impact
Yolanda. Exactly. Thank you, and thank you so much for hosting, Yolanda, and thank you everyone for coming.
And thanks for the questions from the audience. They were brilliant as well. Thank you so much.
Yes, absolutely. Thank you. All right. Have a good evening, everyone.
Bye.
Have a good evening.
Bye. Thank you. Bye.